Hi everybody, and welcome to our module on gastrointestinal anatomy. Here's a drawing of the gastrointestinal tract, which you are all hopefully familiar with. It begins at the oral cavity and goes all the way to the anus, and it includes the intestines, the stomach, and the esophagus. What we're going to do in this module is go through a couple of key structures that you should know for step 1 of your boards. And we're also going to take a look at some CAT scans because the structures in the abdomen of the GI tract are fairly easy to recognize on a CAT scan. And you're often asked to do this on your board, so you need to have seen these structures before by CT so you can recognize them in questions. These are two coronal slices through the abdomen. The CT scan on the left is more towards the front of the abdomen. The one on the right is more towards the rear. One of the first things I want to point out to you is that the liver, which I'm marking with my pen here, is very high up in the abdomen. And this is helpful when you look at axial slices, as we will do later in this module. When you see the liver, you know that you are fairly high up. You can see a structure diving into the middle of the liver here. That is the portal vein carrying blood from the GI tract. Down at the bottom of this picture is the bladder. In the middle of this picture, you can see structures that are filled with white material. That white material is oral contrast. This patient drank oral contrast before this picture was taken, and the oral contrast is filling the colon and intestines and turning them white. The pancreas is visible here in the middle of the abdomen. It's hard to delineate the edges, but I'm circling it with my pen for you here. In the top left of this picture, you see a structure that has some black holes to it here. Black means air, and the only places you should see air in the abdomen are inside the stomach or the intestines. So when you see a structure filled with air in the top left, that is the stomach. If you look at the picture on the right, we're more towards the back of the abdomen. You can still see the liver here, but you see much less of it. You can clearly see the two kidneys. There's a solid structure here in the top left. You might be tempted to think that that's the stomach, but it is a solid structure not filled with air, so that is the spleen. You can still see a bit of the bladder down here at the bottom. There are structures filled with air in here, so those are distal parts of the colon and parts of the rectum. And then you can clearly see the muscles in the back of the abdomen on this picture. These are the psoas muscles and these are the iliacus muscles. Now we're looking at axial slices through the abdomen, and because you can see the liver, you know that you are fairly high up in the abdomen. There's a structure here that contains air. You can see these black parts, so this is the stomach. We have the spleen back here on the left side. And when I look at axial slices of the abdomen, I like to orient myself by finding the aorta. It always sits right on top of the vertebral body, slightly on the left side of the patient's body. Just to the right of the aorta, you can find the IVC, which is right here. And we still see portions of the portal vein over here in the middle of the liver. Now I've moved further down in the abdomen. We're still seeing some liver, but we're seeing less of it. Now you can clearly see the portal vein diving into the liver here. We see the tops of the kidneys on both sides of the body. Once again, you can orient yourself by finding the aorta right here, and to the right of the aorta, the IVC right here. This is the stomach here. It's filled with air, so you know it's either stomach or intestines. These are pieces of intestine over here. We've got a bit of the spleen back here. And when you're at this level of the abdomen where you see the portal vein and some of the liver, and you see this snake-like structure in front of the aorta, that is the pancreas. I'm circling the pancreas with my pen right here. Now we've gone further down in the abdomen. We're not seeing much of the liver anymore. You can see the gallbladder now. You can still see the two kidneys right here. You can still find the aorta here, and this is the IVC over here. And in the front of the abdomen here, we're seeing portions of intestine and colon filled with air in contrast. Now we're very low down in the abdomen. We're not seeing much of the liver at all. We're at the bottom of the kidneys right here. You can easily see the psoas muscles and the erector spinae muscles here. The aorta is where it always is, slightly to the left on top of the vertebral body. Now the IVC is right here next to it. And we've got portions of bowel in the lower abdomen sitting here in the front of the picture. Now what I want to do is talk about the difference between intraperitoneal and retroperitoneal structures. Intraperitoneal structures in the abdomen are structures that are completely covered by mesentery. The mesentery is visceral peritoneum, and when it completely wraps an organ or a structure, we call that organ or structure intraperitoneal. And the stomach, the appendix, the liver, and the spleen are intraperitoneal structures. So are portions of the small intestine, the colon, and the pancreas. In the small intestine, the first part of the duodenum and the jejunum and ileum are intraperitoneal. In the colon, the transverse colon is intraperitoneal, so are the sigmoid colon and some of the rectum. The rectum is a mixture of intra and retroperitoneal structures. And then finally, in the pancreas, only the tail is intraperitoneal. Retroperitoneal structures, on the other hand, are not completely covered by mesentery. Most of them sit in the back of the abdomen. They may have mesentery over their front portion, but they are not wrapped in mesentery like intraperitoneal structures. Two of the most important retroperitoneal structures are the aorta and IVC. The reason these are important is because when these structures bleed, patients will develop blood in the back of the abdomen. We call that retroperitoneal bleeding. The kidneys are retroperitoneal organs, and so are the portions of the small intestine, colon, and pancreas that I did not mention on the last slide. In the small intestine, the distal 2/3 of the duodenum are retroperitoneal. In the colon, the ascending and descending colon are retroperitoneal, and so is a portion of the rectum, like I said before. And then finally, in the pancreas, the head and the body are retroperitoneal. And this is important on your surgical rotations. Many cancers of the pancreas occur at the head, and in order to operate on them, the surgeon needs to get all the way to the retroperitoneal space. I mentioned before that retroperitoneal bleeding is a serious condition that many patients can develop, and you can see this on CAT scan. This is a CAT scan of someone with an RP bleed. This is a large hematoma here in the back of the abdomen. There are many causes. This is often a complication of surgical procedures. In my field of cardiology, patients who have an angioplasty have catheters inserted into their femoral artery, and if the catheter is inserted too high and it begins to bleed, their retroperitoneal space can fill with blood, and we call that a retroperitoneal or RP bleed. You should be aware that the peritoneal cavity is divided into two sacs, the greater and the lesser sac. The greater sac is the entire width of the abdomen, and it goes from the diaphragm to the pelvic floor. Most structures in the abdomen are in the greater sac. When you do surgical rotations and you enter the abdomen anteriorly, you initially enter the greater sac. The lesser sac is a smaller closed space. It's behind the liver and stomach and behind the lesser omentum. There is a hole that leads from the greater sac to the lesser sac, and that is called the epiploic foramen. It's also sometimes called the omental foramen or Winslow's foramen, and it's an opening between the greater and lesser sacs. This picture nicely shows the greater and lesser sac. The greater sac is everything in red. You can see that most of the peritoneal cavity is the greater sac. The lesser sac is this blue cavity that's much smaller. It's behind the stomach. This is the stomach, this structure right here. It sits behind the stomach. And just above the stomach is a small hole that you can put your finger through when you do surgical operations to go from the greater to lesser sac, and that is called the epiploic foramen. The last topic I'll discuss in this module is the anatomy of the anal canal. If you look at this picture over here on the right, this is a drawing of the anal canal. And if you look closely at the lining of this drawing, you can see that there is this portion where there are these tooth-like projections here, which I'm drawing my pen around. And that is called the pectinate line. It's also sometimes called the dentate line or the anocutaneous line. The words pectinate and dentate mean teeth-like, and these look like teeth-like projections of the mucosa. This line is very important anatomically because the structures above the line are different from the structures below the line. The GI tract above the line is all derived from the hindgut. It contains columnar epithelium just like other epithelium in the digestive tract. It's similar to the colon and other structures. Below the line, everything is derived from the proctodeum, which is portions of the ectoderm. This is very similar to skin. It's stratified squamous epithelium. So you have different tissue types above and below the pectinate line. This is important clinically because the anatomy and the pathology above the pectinate line is different from that below. Let's talk about above the pectinate line first. The blood supply above the pectinate line comes from the superior rectal artery. This is a branch of the IMA, much like the distal colon. The venous drainage is via the superior rectal vein to the inferior mesenteric to the portal system. This means that patients who have cirrhosis and portal hypertension may see swelling of the venous structures above the pectinate line. This can result in internal hemorrhoids. And internal hemorrhoids have visceral innervation just like everything above the pectinate line, and this means that these are usually non-painful hemorrhoids. The lymph drainage above the pectinate line is via the internal iliac lymph nodes, and then finally, when cancers of the anal canal occur above the pectinate line, this is rare, they are usually adenocarcinomas. This is also much like the cancers that occur in the distal colon. Below the pectinate line, things are different. The blood supply here is from the inferior rectal artery. This is a branch of the internopudendal artery off the iliac artery. The venous drainage is to the inferior vena cava. It goes via the inferior rectal vein to the internal pudendal vein, to the internal iliac, and then to the IVC. So you will not see hemorrhoids and swelling of these veins in patients with portal hypertension because this venous system does not drain into the portal system. The lymph drainage here is to the superficial inguinal nodes. This is just like drainage from skin. Remember I said that the epithelium here is very similar to skin. So you can palpate lymph nodes in the groin in patients who have problems occurring below the pectinate line in the anal canal. There is somatic innervation to this area of the anal canal, so hemorrhoids that occur here are painful, and we call hemorrhoids below the pectinate line external hemorrhoids, and those are painful hemorrhoids. And then finally, when patients develop anal cancer in this portion of the anal canal, it is a squamous cell carcinoma. and this is the more common form of anal cancer. Lastly, I'll mention a rare congenital anomaly called an imperforate anus. The hindgut and the ectoderm need to meet to form the anus. If they do not form the anus, you will have what's called an imperforate anus. And this occurs commonly in association with genitourinary malformations in newborn babies. They are often born with renal agenesis, meaning they lack one or both kidneys. They are also often born with bladder exstrophy, where the bladder is outside of the body. These pathologies occur in conjunction with imperforate anus frequently. And the presentation is a baby that fails to pass meconium, obviously because they do not have an opening in their anal canal, or where meconium passes through the urethra or the vagina because of a fistula. That concludes our module on gastrointestinal anatomy.